So we were discussing about the duodenum. Now we'll start the jejunum. Okay, so before going into the jejunum, I'll just add a small thing related to jejunum and ileum. Okay, so if you see the jejunum and ileum, okay, so we'll discuss jejunum and ileum together. Jejunum and ileum. Okay, jejunum and ileum together it forms a part of the small intestine distal to the duodenum. Okay, so both of them, if they measure together, they measure approximately 6 meters in length. Okay, they measure approximately 6 meters in length, and both of them are intraperitoneal organs. They are intraperitoneal in nature. They are intraperitoneal in nature. Okay, they are intraperitoneal in nature. Fine. So they are suspended by a fold of peritoneum called as mesentery. They are suspended by a fold called as mesentery. Okay, they are suspended by a fold called as mesentery. Okay, so if you take the mesentery, okay, if you take the mesentery, okay, so let us consider yes, okay, so yes, so if you see the mesentery, okay, if you see the mesentery, Mohandan, yes, you are right. Celiac trunk supplies only up to the mid part of the second part of the duodenum. Rest part is supplied by the superior mesenteric artery, that is a branch of inferior pancreatic duodenal artery. It supplies the duodenum, that is a part of superior mesenteric artery. You are right, yes. So when you see the mesentery, okay, when you see the mesentery is a fold of peritoneum, okay, which extends from the posterior abdominal wall to the intestine, okay, to the intestine. So this is a fan shaped structure. This mesentery is a fan shaped structure. So this is a fan shaped structure, and you have got lot of fat being present in this mesentery. You have got lot of fat being present in this mesentery. And if you see the mesentery, okay, so the mesentery is attached, okay, the mesentery is attached to the left side to the duodenojejunal flexure. To the left side, the mesentery is attached to the duodenojejunal flexure, okay, and from the left side, okay, it crosses down to the right side. It crosses down to the right side and it ends at the ileocecal junction. It ends at the ileocecal junction. This is called as a ileocecal junction. So what we are discussing is the attachment of root of mesentery, attachment of a root of mesentery. Okay, so this root of mesentery, okay, this root of mesentery is about 15 centimeter in length, is about 15 centimeter in length, and it is attached to the duodenojejunal flexure on the left side, and it is down, it runs downwards, okay, it crosses the midline of the abdomen, it runs downwards and it ends at the ileocecal junction. Okay, so when it ends at the junction, on the way it crosses certain structures. So initially it crosses the abdominal aorta, okay, then it crosses the third part of the duodenum, then it crosses the third part of the duodenum, then it crosses the psoas major muscle, then it crosses the psoas major muscle, okay, and it also crosses the ureter on the right side. It also crosses the ureter on the right side. So these are the structures which are crossed by the root of the mesentery. Okay, so I'll put it here. So structures crossed by the root of the mesentery, structures crossed by the root of the mesentery, structures crossed by the root of the mesentery are one, okay, one, it is the aorta is being crossed by it, the third part of the duodenum, the third part of the duodenum is crossed by this, okay, the third part of the duodenum is crossed by this, the right psoas major muscle, the right psoas major muscle is crossed by this, and the right ureter and the right ureter is also crossed by the root of the mesentery. Okay, so it runs in a downward direction towards the right side. This is about 15 centimeter long, and it is going to hold on the other hand a 6 meter long tube. So this border where the mesentery is attached to the intestine is called as a mesenteric border, and the border which is devoid of the mesenteric attachment is called as the anti-mesenteric border. It is called as an anti-mesenteric border. It is called as an anti-mesenteric border. Okay, now what is the function of this mesentery? This mesentery is going to supply the blood vessels to the intestine, is going to supply the blood vessels to the intestine. Now what are the two intestines we are discussing about? We are discussing about jejunum we are discussing about the jejunum and we are discussing about the ileum. Okay, what are the characteristic difference between these two? Okay, so in jejunum, if you see, okay, the walls of the jejunum are thick. Okay, the walls of the jejunum are thick. Here the walls of the jejunum are thin. Okay, jejunum occupies the upper left quadrant of the abdomen. It occupies the upper left quadrant of the abdomen, whereas this ileum occupies the right lower quadrant of the abdomen. Right lower quadrant of the abdomen is occupied by the ileum. Right lower quadrant is occupied by the ileum. Okay, if you see the jejunum fold, okay, if you see the jejunum, let us consider this is the jejunal tube and this is the mesentery and this is the mesentery. So the vessels which enters the mesentery supplying the jejunum will form an arterial arcade like this. They form an arterial arcade like this. So here the arterial arcades are less. Maybe you will see only 2 to 3 arterial arcades. You will see only 2 to 3 arterial arcades. Okay, you will see only 2 to 3 arterial arcades, and from this arterial arcades you got vessels which supplies the duodenum. So vessels which supplies the jejunum. Okay, and these vessels are called as vasa recta. They are called as vasa recta. Okay, so here the vasa rectas are longer. Here the vasa rectas are, recta means straight, vasa means vessel. So these vasa rectas are longer in the jejunum. These vasa rectas are longer in the jejunum. Okay, but when you come here, when you come to this area, okay, when you come to this area, okay, so let us consider this is the ileum again, and this is the mesentery again, mesentery here. So when the vessels reaches the ileum, okay, they again form arterial arcades. But what is different from jejunum is, here the number of arterial arcades are more. Here the number of arterial arcades are more. Okay, so there are more number of arterial arcades. Because the arterial arcades are more, the vasa recta becomes shorter here. So okay, here you got more arterial arcades. So because of the more arterial arcades, here the vasa rectas are shorter. Okay, and in the jejunum what you see will be mostly often solitary lymphatic follicles. You will have solitary lymphatic follicles. Okay, you will have solitary lymphatic follicles, whereas here the lymphatic follicles, okay, here the lymphatic follicles are aggregated to form a patch called as Peyer's patches. They form a patch called as Peyer's patches. Guys, anybody can tell me in which condition Peyer's patches can get inflamed? In which conditions the Peyer's patches can get inflamed? Okay, can anybody tell me one condition where Peyer's patches inflammation are? Yes, very good, Anashwara. Yes, very good. In typhoid fever, Peyer's patches get inflamed, and when the Peyer's patches inflamed, they can form an ulcer there, and usually these ulcers are situated, okay, with their long axis, okay, along the intestine, okay, with the long axis along the long axis of the intestine, okay, with the long axis along the long axis of the intestine. Okay, and when you see the fat, okay, when you see the fat here, so here there will be complete fat, okay, but here you can see lot of windows in the fat. So what you see here is okay, so what you see here is the fat is less, here the fat is thick, okay, you see thick fat in the mesentery of the ileum. Okay, you will see thick fat in the mesentery of the ileum. So you will have thick fat, guys, here. So you will have thick fat here, and the fat is thin here, okay. So you will have fat is less in the mesentery of the jejunum, where the fat is more in the mesentery of the ileum. Okay, so these are all certain basic differences between jejunum and ileum. And what is the blood supply for these vessels? So the jejunal and the ileal branches, of the superior mesenteric artery. The jejunal and the ileal branches of the superior mesenteric artery is the blood supply for these jejunum and ileum. So the jejunum and ileal branches from the superior mesenteric artery, okay, supplies the jejunum and ileum. So this is about jejunum and ileum, okay. And what is happening to the ileum now? Ileum is opening into so this is ileum, and this ileum is opening into the cecum here, okay. So this junction is called as ileocecal junction. This junction is called as ileocecal junction. So what is this junction? This is called as ileocecal junction, okay. So this ileocecal junction is the narrowest part of the small intestine, okay. So this ileocecal junction is the narrowest part of the small intestine. It is the narrowest part of the small intestine, and when it opens into the cecum, okay, so this orifice is called as ileocecal orifice. This orifice is called as ileocecal orifice. About 2 centimeter below the ileocecal orifice, about 2 centimeter below the ileocecal orifice, on the posteromedial wall of the cecum, you have this organ, okay. This is a vestigial organ, and this organ is called as appendix. This is called as an appendix, okay. This is called as an appendix, okay. Appendix. Now my question is, appendix is an intraperitoneal organ or it is an retroperitoneal organ? Can anybody tell me appendix, it is an peritoneal organ or it is an retroperitoneal organ, guys? Yes, appendix is what kind of organ? Yes, appendix is an peritoneal organ. Very good, it is a peritoneal organ, okay. So where is this peritoneum derived from? So you have the mesentery here. The ileum is suspended by the mesentery. The lower portion or the posterior wall of the mesentery gives rise to this colon. This colon is called as mesocolon, okay. This is called as mesocolon of the appendix, okay. So this appendix has got mesocolon here. So this is called as a mesentery of the appendix. This is called as a mesentery of the appendix. This is called as a mesentery of the appendix, also called as mesoappendix, okay. Also called as mesoappendix. This is called as mesoappendix, okay. If you want to see it in another view, okay, so let us consider this is the ileum, okay. Let us consider this is the ileum. We all know that ileum is suspended by mesentery, okay. It has got 2 leaflets, an upper leaflet and a lower leaflet. From the lower leaflet, okay, from the lower leaflet runs this fold, okay, which suspends the appendix, okay, which suspend the appendix. So what is this? This is ileum, and this is appendix, okay. This is appendix. What is this? This is mesentery, So from the posterior leaflet you get this is called as mesoappendix. This is called as what? This is called as mesoappendix. Okay. So mesoappendix is the one which is holding the appendix, okay. So if you take the appendix position is very variable, guys. It is very variable, okay. So appendix can be seen in number of positions, okay. So if you see the appendix, so let us consider this is the colon, okay. So this is the ileum, okay, and this is the appendix. So appendix can lie in several positions. It can lie in 11 o'clock position, it can lie in 12 o'clock position, it can lie in 2 o'clock position, it can lie in 3 o'clock position, it can lie in 4 o'clock position, or it can lie in 6 o'clock position. It can lie in so many positions, okay. It can lie in so many positions. So this is called as the 11 o'clock position, okay. So this position is called as the, okay, this position is called as a 12 o'clock position, okay, 12 o'clock position, okay. This is the retrocecal position, and retrocecal position is the most common site of appendix. This is the most common site of appendix, okay. This is the most common site of appendix. So this position is called as a 2 o'clock position, also called as splenic type, okay. So when it lies towards the spleen, it is called as splenic type. In this, either it can lie in front of the ileum, which is called as pre-ileal type, or it can lie behind the ileum, which is called as an post-ileal type, Here it is called as an 3 o'clock position, okay. This is pointing towards the sacral promontory. This is pointing towards a sacral promontory, so it is called as an promontoric type. 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 Okay, sometimes it can point down to the 4 o'clock position. Okay, sometimes it can point down to the 4 o'clock position. Okay, or it can point towards the 6 o'clock position. Okay, it can point towards the 6 o'clock position. Of this, the 4 o'clock position is the second most common type. It is the second most common type. It is the second most common type. Okay, it is the second most common type. The 4 o'clock position is called as an pelvic type, and the 6 o'clock position is called as an subcecal type. It is called as an subcecal type. It is called as an subcecal type. It is called as an subcecal type. So most important is the most common location of appendix is this, that is retrocecal position or 12 o'clock position. Retrocecal position or 12 o'clock position. Okay, now how you identify appendix intraoperatively? Intraoperatively, it is the collection of 3 tinea coli at one point. So that you know that there are 3 tinea coli in the large intestine. So if you take the large intestine has got the following features. Okay, the large intestine has got following features. The longitudinal muscle coat of the large intestine, they form bands. Okay, they form bands. I hope you know that there are 2 types of muscle coat in the intestine. One is called the inner circular layer and the outer longitudinal layer. So the outer longitudinal layer, okay, the outer longitudinal layer, okay, the outer longitudinal layer in the large intestine aggregates to form a structure called as okay, tinea coli. They are called as tinea coli. Okay, they are called as tinea coli, and this tinea coli, okay, they all converge to the base of the appendix. They all converge towards the base of the appendix. Okay, so all this tinea coli, they converge to the base of the appendix. They converge to the base of the appendix. So based on this, you can identify the base of the appendix. Okay, when the appendix is inflamed, okay, you will have appendicitis, especially in this region. So this is one feature of large intestine where you get tinea coli. In the large intestine, you will have these dilations. These dilations are called as sacculations. These are called as sacculations. So what are these? These are called as sacculations. Okay, and when you see the large intestine, the large intestine has got pouches of peritoneum. It has got pouches of peritoneum with the fat in it. Okay, so you got fat within this. So the fat within this peritoneal pouches are called as appendices epiploicae. They are called as what? They are called as appendices epiploicae. They are called as appendices. They are called as appendices epiploicae. Okay, they are called as appendices epiploicae. So usually if it is a large intestine, there will be tinea coli, there will be sacculations, and there will be appendices epiploicae, and all these 3 are absent in the appendix. In appendix you don't see these findings. Okay, and the base of the appendix can also be identified, okay, by drawing a line called as or by identifying a point called as McBurney's point. Very very important surface anatomy question. It's called as McBurney's point. What is called as McBurney's point? So if you take the anterior superior iliac spine, and if you take the umbilicus, you connect the anterior superior iliac spine and the umbilicus by a line. You divide it into lateral 1/3 and medial 2/3. The junction of the lateral 1/3 and medial 2/3 of this line is called as a McBurney's point. So what is this bony landmark? This is called as anterior superior iliac spine. Anterior superior iliac spine. And what is this? This is the umbilicus. This is the umbilicus. Okay, this is umbilicus. Okay, this is umbilicus. And when you draw a line connecting these two, and when you take the junction of the lateral 1/3 and medial 2/3, that point is called as McBurney's point. Tenderness at the McBurney's point indicates that the patient has got, okay, the probe tenderness, okay, or the tenderness at the McBurney's point results in, or it tells you that the patient is suffering from appendicitis. Now there is a question again related to ortho waist. So see, there is a tuberosity here, ischial tuberosity. If I draw a line from ischial tuberosity to anterior superior iliac spine, okay, can anybody tell me what is the What is the, yes, very good Prithviraj, you have answered that tinea coli question also, very good. So now can you answer this question, that when you draw a line between the ischial tuberosity to the anterior superior iliac spine, when you draw a line from ischial tuberosity to anterior superior iliac spine, what is this line called as? What is this line called as? Anybody guys? If you draw a line from the ischial tuberosity to the anterior superior iliac spine, what is this line called as? Anybody? Can anybody tell me what is this line called as? This line is called as Neelaton's line. This line is called as, very good Charu, this is called as Neelaton's line. This is called as Neelaton's line. Okay, this is called as Neelaton's line. Suppose if you extend the Neelaton's line to the umbilicus, if you extend this line to the umbilicus, what is this line called as? Okay, if you extend the line to the umbilicus, what is this line called as, guys? What is this line called as? If you extend the line from the anterior superior iliac spine, if the Neelaton's line is extended to the umbilicus, then you call this line as the shoemaker line. You call this line as the shoemaker line. Very good Adira, very good. It is called a shoemaker line. It is called as shoemaker line. Okay, so there are 4 things you should understand. There is a triangle called as Bryan's triangle. There is a triangle called as Bryan's triangle. There is a line called as Neelaton's line. There is a line called as Neelaton's line. There is a line called as shoemaker's line. Shoemaker's line. There is a line called as shoemaker's line. And there is a parallelogram called as Cheney's parallelogram. Cheney's parallelogram. So all this line, okay, all these are to find out whether there is an supratrochanteric shortening in femur, whether there is an supratrochanteric shortening in the femur. Okay, so to identify whether there is any shortening in the supratrochanteric region of the femur, okay, shortening, to identify the shortening in the supratrochanteric region of the femur, we draw these lines. Okay, so McBurney's point also lies along these lines, so I just want to tell about these lines. Okay, it is okay, so it is called as the supratrochanteric shortening of femur, which can be identified by drawing these lines and this triangle. Okay, so this is about the appendix. Okay, this is about the appendix, and if you see the appendix, the orifice of the appendix, the appendicular orifice. Okay, so you see the appendicular orifice, and this appendicular orifice is guarded by a valve called as valve of Gerlach. It is guarded by a valve called as valve of Gerlach. It is guarded by a valve called as valve of Gerlach. So this appendicular orifice is present 2 cm below the iliocecal junction. Appendix is supplied by appendicular artery. Appendix is supplied by what? It is supplied by appendicular artery. It is supplied by appendicular artery. Okay, it is supplied by appendicular. It is a branch of ileocolic artery. It's a branch of ileocolic artery which is derived from superior mesenteric artery. So appendicular artery is derived from indirectly from the superior mesenteric artery. It is indirectly derived from the superior mesenteric artery. Okay, so fecoliths are common in appendix. Okay, fecoliths are common in appendix. So this fecoliths can occlude the appendicular orifice, resulting in appendicitis. So whenever appendicitis happens, they do a surgery called as appendicectomy. And can anybody tell me, when they do appendicectomy, what is a nerve that is commonly injured? Yes guys, what is a nerve that is commonly injured when they do appendicectomy? What is a nerve that is commonly injured? Yes, very good guys, it is the iliohypogastric nerve. Excellent guys, excellent. It is iliohypogastric nerve. And can anybody tell me what is the supply of iliohypogastric? Iliohypogastric supplies which region? Anybody? Iliohypogastric supplies what is the area supplied by iliohypogastric nerve? Yes guys, iliohypogastric nerve. Yes, iliohypogastric nerve supplies the lower abdominal muscles. So you know external oblique abdominis muscle, you know the internal oblique abdominis muscle, you know the transverse abdominis muscle, the lower part of these muscles are supplied by iliohypogastric. Just imagine when these muscles become weak, what can happen in them? When these muscles become weak, there is already a potential weakness in the lower part of the abdomen, which is called as inguinal region. So when these muscles become weak, then it results in inguinal hernia. This is a classical finding a patient can present with. So when a patient has got an appendix surgery, few years later he presents with an hernia, then it is an indirect evidence that there is a high chances for the iliohypogastric nerve to be injured. Okay, very good guys. So this is about the appendix and the appendicular artery. Okay, nothing much about the other intestines. Okay, ascending colon, descending colon, transcolon, nothing much in them. Few things I will just add here. Okay, if you take the cecum, okay, so if you take cecum, okay, so carcinomas in the cecum, okay, or carcinomas in the other part can give a classical appearance called as apple core appearance. It gives an appearance called as apple core appearance in X-rays. It gives an appearance called as apple core appearance. Okay, when you take the sigmoid colon, the sigmoid colon is suspended. Okay, it is suspended by a peritoneum called as sigmoid mesocolon. Okay, so this sigmoid mesocolon can twist around itself, resulting in a condition called as valvulus. Okay, so whenever an organ is an intraperitoneal organ, the organ can twist around the peritoneal fold, resulting in valvulus. Stomach can go in for valvulus. Okay, small intestine can go in for valvulus, sigmoid colon can go in for valvulus. So whenever there is a valvulus happening, okay, so you can get certain signs again. So if you see the X-ray, you can see get a sign called as coffee bean sign. They will teach all these things in radiology. Okay, so just I am giving a refresher here. So then they also give a sign called as bent tire tube sign. So it gives a sign called as bent tire tube sign. Okay, so coffee bean sign or bent tire tube sign are all seen in sigmoid valvulus or seen in sigmoid valvulus. So these are all the important things which are related here. And to conclude this area, okay, so just I need to draw this diagram again. Okay, so this is the ascending colon, cecum, appendix, okay, and the ileum. Okay, ileocecal junction is here, ascending colon is here, transverse colon is here. So this is transverse colon, and this is the splenic flexure, and this is the descending colon. Okay, and this is the sigmoid colon, the rectum, anal canal, and the rectum and anal canal. If you see the blood supply of this, okay, if you see the blood supply of this, guys, I think my screen is not visible. Yes, okay, so when you see the blood supply of this large intestine, okay, you know that there is an important artery which is running here. Okay, so this artery is the superior mesenteric artery. It is running behind the transverse colon. So remember this is an important point. Superior mesenteric artery is running behind the transverse colon, and this superior mesenteric artery, okay, it gives rise to the jejunal and the ileal branches on the left side, and on the right side it gives rise to the ileocolic branches. Okay, it supplies the ileum, distal ileum, unto the colon, okay, unto the cecum, unto the ascending colon. It also gives a branch called as a right colic artery. And it also gives a branch called as a middle colic artery. And up to what region they supply? They supply up to the right 2/3 of the transverse colon. So up to right 2/3 of the transverse colon, up to right 2/3 of the transverse colon, the blood supply is by superior mesenteric artery. The blood supply is by superior mesenteric artery. Okay, so now the next comes in another artery from the aorta, okay, at the level of L3 running towards the left side. This is called as the inferior mesenteric artery. What is this? This is called as the inferior mesenteric artery. This is called as an inferior mesenteric artery. This inferior mesenteric artery gives rise to left colic branch. It gives rise to left colic branch. Okay, it also gives sigmoid branches. It also gives a branch to the rectum, which is called as a superior rectal artery. Okay, we'll just write the name of these vessels. So what is this? This is called a superior mesenteric artery. This is called a superior mesenteric artery. These branches are called as the jejunal branches and the ileal branches. Jejunal and the ileal branches. These are called as the jejunal and the ileal branches. This branch, what you see here, is called as the ileocolic branch. It is called as the ileocolic branch. This branch, what you see here, is the right colic branch. It is called as the right colic branch. And the branch what you see here is called as the middle colic branch. It is called as the middle colic branch. So through these branches, the superior mesenteric artery supplies the large intestine up to the junction of the right 2/3 of the transverse colon. Okay, so the inferior mesenteric artery, okay, gives rise to the left colic artery. It gives rise to the left colic artery. It gives rise to the sigmoid arteries. And it also gives rise to the superior rectal artery, which supplies the rectum. This is superior rectal artery supplying the rectum. Okay, now all these vessels forms an anastomosis around the intestine. This anastomosis is called as marginal artery of Drummond. So this anastomosis is called as what? This is called as marginal artery of Drummond. Okay, this is called as marginal artery of Drummond. So these arteries will anastomose with one another. Okay, but there is one potential area where this anastomosis is poor. Okay, so at the splenic flexure, okay, so this anastomosis is weak. It is poor in this area. So in the splenic flexure, this anastomosis is weak. So if there is any ischemic changes to happen due to a reduced blood flow, okay, either through the superior mesenteric artery or through the inferior mesenteric artery, splenic flexure is one area which can get commonly affected, and that point is called as Griffith point. So that point is called as Griffith point. This is what they have given in your workbook. Okay, so Griffith point is seen at the splenic flexure. Okay, it is seen at the splenic flexure. So it is a junction of the superior mesenteric artery and the inferior mesenteric artery. The anastomosis is poor here because of the poor anastomosis. Okay, this junction can easily go in for ischemic colitis. Okay, so that junction is called as in Griffith point. Okay, fine. So that junction is called as in Griffith point. So this is about the blood supply of the small intestine, blood supply of the large intestine, and their applied aspect. Okay, so keeping this in background, we'll go to the next part of the abdomen, that is the renal system, okay, and the urogenital system. Okay, so see, if you take the urogenital system, okay, so urogenital system arises from a mesoderm called as intermediate mesoderm. You got three mesoderms. Okay, so the intra-embryonic mesoderm, we call that as an intra-embryonic mesoderm. This intra-embryonic mesoderm is divided into three parts. Okay, one is called as an para-axial mesoderm, one is called as an para-axial mesoderm. Okay, one is called as an para-axial mesoderm. The next one is called as an intermediate mesoderm. This is called as an intermediate mesoderm. Okay, so this is we are talking about the intra-embryonic mesoderm. Okay, so intra-embryonic mesoderm is divided into three parts. One is called as an para-axial mesoderm, Okay, next is called as an intermediate mesoderm. Next is called as an intermediate mesoderm. Okay, intermediate mesoderm, and there is a mesoderm called as lateral plate mesoderm. There is a mesoderm called as lateral plate mesoderm. Okay, so there is a mesoderm called as lateral plate mesoderm, and it is this intermediate mesoderm which gives rise to the urogenital system. It gives rise to the urogenital system. Okay, it gives rise to the urogenital system. And if you see the intermediate mesoderm, okay, so it is divided into three parts. Okay, initially the proximal part is called as pronephros. Okay, and the middle part is called as a mesonephros. Okay, and the distal part is called as a metanephros. So this is called as a metanephros. This is called as metanephros. So if you see here, initially when the child was developing, okay, the pronephros doesn't function much, it degenerates, but the mesonephros functions initially for few days and acts as an excretory system. But the definitive kidney is arising from the metanephros. Okay, so it is the metanephros which forms the definitive kidney. So metanephros is the one which forms the definitive kidney. Okay, it forms a definitive kidney. Okay, so how it is formed? Okay, so close to the close to the metanephros and the mesonephros, there is an important duct which is running, which is called as a nephric duct. Okay, and from this nephric duct you have a bud called as ureteric bud. Okay, this bud is called as an ureteric bud, and this bud, what happens when it grows towards the metanephros, and when it touches the metanephros starts to differentiating. Okay, so it is because of the influence of the ureteric bud, so the metanephros starts to differentiate and forms the kidney. So if you see the metanephros forms the excretory part. Okay, it forms a filtration unit of the filtration unit of the kidney. Okay, it forms a filtration unit of the kidney, whereas the collecting part, the collecting unit is derived from the ureteric bud. So the collecting unit is derived from the ureteric bud. Okay, so the filtration unit is developed from the metanephros, whereas the collecting unit is derived from the ureteric bud. Okay, so keeping this in basis, so the kidney is developing from the definitive kidney is developing from metanephros. And if you see here, kidney is developing lower down, it is developing in the pelvic region, and then it ascends to the lumbar region, so kidney is developing in the pelvic region and then it ascends. So usually kidney ascends. Okay, and the testis, and the gonads, testis or ovary, it descends. Okay, it is the kidney which ascends from the pelvic area to the lumbar area. When it ascends, it carries the ureteric bud along with it, forming the ureter. Okay, so this is about the development of the kidney. When you see the kidney is an organ which is occupying, okay, so kidney is an organ which is occupying mainly the lumbar region. It also extends a little bit into the umbilical region. Okay, it enters into the umbilical region. Okay, and it also is related to the epigastric region a bit. Okay, and also to the hypochondriac region. So it is also related to the hypochondriac region. So the kidney is just related to these quadrants of the abdomen. Okay, these quadrants of the abdomen. And when you see the two kidneys, the right kidney is at a lower level compared to the left kidney because of the huge organ on the right side, that is the liver. Okay, so when you take the kidney has got a lot of relationship around it. Okay, so these are the anterior relationship of the kidney. Okay, if you see the kidney on the right side, the right kidney is related to the suprarenal gland. Okay, and it is related to the liver. Okay, so yesterday we saw the kidney and the liver relationship. Okay, so you know that liver is here, kidney is here. Okay, and the right kidney is here, and there is a reflection of the peritoneum from the liver to the right kidney, and they form a pouch. We discuss about the pouch. This pouch is called as Morison's pouch. Okay, this pouch is called as Morison's pouch. Okay, this pouch is called as Morison's pouch. Okay, this pouch is called as Morrison's pouch. Okay, so this is called as hepatorenal pouch of Morrison. We discussed about it. So this is the hepatic area which is related to the right kidney. Okay, this is the hepatic area which is related to the right kidney. Okay, yes. Okay, so yes guys, I have just adjusted my screen now. Okay, fine. So this is about the liver. This is about the liver which is related to the right kidney. The next comes the duodenum, and I have told you it is the second part of the duodenum which is related to the liver. Okay, and next comes the colic area. And what is this colon which is related to the kidney? It is the hepatic flexure of the colon. It is the hepatic flexure of the colon which is related to the kidney. Okay, it is the hepatic flexure of the colon which is related to the kidney. And to the lower pole, it is the jejunum which is related to the right kidney. Okay, it is the jejunum which is related to the right kidney. And when you come to the left kidney, okay, the left kidney is related to the left suprarenal gland. Okay, left suprarenal gland, stomach, spleen, pancreas are all related here. And this colon which is related here is the splenic flexure of the colon. It is the splenic flexure of the colon. It is the splenic flexure of the colon which is related here. Okay, and jejunum is also related to the anterior surface of the left kidney. See, when you take the relationship of the kidney, most of the time questions don't come from the anterior relationship, but questions comes from the posterior relationship of the kidney. So we'll go to the posterior relationship of the kidney. So this is very important area. So if you see the posterior relationship of the kidney, this is the left side. Okay, this is the right side kidney. So because how I say the right kidney is at a lower level compared to the left kidney, you can see the right kidney is at a lower level compared to the left kidney. So they have turned the kidney and they are showing you. So this is about the posterior relationship of the kidney. So when you see the kidney on the right side, the kidney is related to the 12th rib. Okay, it is related to the 12th rib. Okay, on the right side, and on the left side it is related to the 11th and the 12th rib. It is related to the 11th and the 12th rib, and it is related to the 11th intercostal spaces. It is related to the 11th intercostal spaces. Okay, and close to the upper pole of the kidney, the kidney is also related to two ligaments of the diaphragm. Two ligaments of the diaphragm are related to the kidney here. So the two ligaments of the diaphragm which are related to the kidney are the medial arcuate ligament. This is called as medial arcuate ligament. So this ligament is called as medial arcuate ligament, and there is another ligament which is seen here. This is called as an lateral arcuate ligament. This is called as an lateral arcuate ligament. This is called as a lateral arcuate ligament. So you got medial arcuate ligament and lateral arcuate ligament which are related to the kidney posteriorly. Okay, so what are these ligaments? These ligaments are related to the diaphragm. It is from these ligaments the diaphragm also takes its origin. So these are all called as the medial and the lateral arcuate ligament. Okay, now below the ribs, the kidney is related to three groups of muscles. The muscle what you see here is the muscle called psoas major, and this muscle is called as a quadratus lumborum. This is an area for quadratus lumborum. This is called as quadratus lumborum, and the muscle what you see here is called as a transverse abdominis muscle. This is called as transverse abdominis muscle. So when you see the posterior relationship of the kidney, on the medial side it is related to the psoas major. Okay, then it is related to the quadratus lumborum, and then it is related to the transverse abdominis muscle. Okay, the kidney is also related posteriorly to three nerves. Okay, there are three nerves which are related to the kidney posteriorly. Okay, what are the three nerves that are related to the kidney here? Okay, I'll just mark on this side. So this nerve is called as a subcostal nerve. This is called as a subcostal nerve. Okay, and this nerve is called as the helio-hypogastric nerve. This is called as an helio-hypogastric nerve, and this nerve is called as an helio-inguinal nerve. This is called as an ilioinguinal nerve. So there are three nerves which are related to the kidney posteriorly. One is called as a subcostal nerve, next is called as an iliohypogastric nerve, next one is called as an ilioinguinal nerve. So these three nerves are related to the kidney posteriorly. There is also a vessel which is related to the kidney, which is running with the subcostal nerve. That vessel is called as a subcostal vessel. This is called as a subcostal vessel. Okay, these are the posterior relationship. Very important is posterior relationship. Is very important is posterior relationship. Okay, so many times question comes mainly from the posterior relationship. Anterior relationship of the kidney, they don't ask much. Why? Because why the posterior relationship is important? Can anybody tell me why the posterior relationship of the kidney is important, guys? Yes, why the posterior relationship of the kidney is important? Yes, because when you do surgeries, okay, when you do surgeries in the kidney, mostly the kidney is approached from the posterior aspect. Okay, mostly the kidney is approached from the posterior aspect. Okay, so that is why the posterior relationship is very common. And there is an angle which is found between the erector spinae muscle. If you take the erector spinae muscle on the posterior side, and if you take the 12th rib, okay, so the angle between the erector spinae muscle, if it is erector spinae muscle, and if it is 12th rib, the angle between the 12th rib and the erector spinae muscle is called as a renal angle. This is called as a renal angle. It is through this renal angle they open and reach the kidney. Now when they open and reach the kidney from the posterior aspect, what are the structures they pass through? This is again a question which was asked. So to understand that, I'll just draw a simple diagram. So if you see the spine, so this is the lumbar vertebra, this is the lumbar vertebra, this is the body of the lumbar vertebra, this is the transverse process of the lumbar vertebra, this is the transverse process of the lumbar vertebra. Okay, so this is the lamina of the lumbar vertebra, and this is the spinous process of the lumbar vertebra. So you get a canal here called as the vertebral canal in the center. So this is the parts of the lumbar vertebra. So lumbar vertebra has got a body, it has got transverse process, it has got lamina, and has got a spinous process. So if you see the area between the spinous process and the transverse process, there is a muscle which is seen here, and this muscle is called as the erector spinae muscle. What is this muscle? This muscle is called as an erector spinae muscle. So this muscle is called as erector spinae muscle. Okay, this erector spinae muscle is closed by a sheath called as a thoracolumbar fascia, and this layer of thoracolumbar fascia, what you see here, is called as the posterior layer of the thoracolumbar fascia. This is called as the posterior layer of thoracolumbar fascia. This is called as posterior layer of thoracolumbar fascia. This is called as posterior layer of thoracolumbar fascia. Okay, overlying the posterior layer of thoracolumbar fascia are arising from the thoracolumbar fascia is a muscle, okay, which is seen here. The muscle which arises from the posterior layer of thoracolumbar fascia is the latissimus dorsi muscle. When we studied about latissimus dorsi, we have seen the origin of the latissimus dorsi. That latissimus dorsi also arises from the posterior layer of the thoracolumbar fascia. Okay, attached to the tip of the transverse process. Is nothing but the middle layer of the thoracolumbar fascia. So what is this layer called as? This layer is called as the middle layer of the thoracolumbar fascia. This is called as a middle layer of thoracolumbar fascia. Okay, this is called as middle layer of thoracolumbar fascia, and arising from the transverse process and from the middle layer of thoracolumbar fascia is this muscle, and this muscle is called as the quadratus lumborum muscle. Now what is this muscle called as? This muscle is called as quadratus lumborum muscle. This is called as quadratus lumborum muscle. When you go slightly anterior to the quadratus lumborum muscle, okay, so this is a muscle which is seen here, which is called as a psoas major muscle. This is called as psoas major muscle. psoas major muscle, and this psoas major muscle and the quadratus lumborum muscle are covered by the anterior layer of thoracolumbar fascia. So what you see here is the anterior layer of thoracolumbar fascia, so you got so many muscles in this region. When you go from posterior, you can see the latissimus dorsi here, then you see the erector spinae, okay, then between the anterior layer of thoracolumbar fascia and the middle layer of thoracolumbar fascia you can see the quadratus lumborum and the psoas major muscle. And when you see the thoracolumbar fascia, all the three layers, okay, all the three layers fuse and continuous as the thoracolumbar fascia laterally, and this thoracolumbar fascia gives origin for two muscles posteriorly, okay, two muscles posteriorly, clear. So this muscle what you see here is called as the internal oblique abdominis muscle, and this muscle what you see here is called as a transverse abdominis muscle. Again we are coming to the layers of the abdominal wall, okay. So you know that there are three muscles on the lateral side of the abdominal wall. One is called as external oblique abdominis, next one is called as transverse abdominis, the outermost layer is called as the external oblique abdominis. It is the external oblique abdominis, okay. So this is internal oblique abdominis, okay. So this is internal oblique abdominis and this is external oblique abdominis. Now from the picture, from the diagram, if you see, okay, you can very clearly see the external oblique abdominis muscle, okay. The external oblique abdominis muscle does not arises from, okay, the external oblique abdominis muscle does not arises from the thoracolumbar fascia. It is very clear here. When you see from the posterior aspect, it is very clear the transverse abdominis is arising from the thoracolumbar fascia, internal oblique abdominis is arising from the thoracolumbar fascia, whereas the external oblique abdominis muscle is not arising from the thoracolumbar fascia. Now you get a area between these two muscles here, you get an area between these two muscles here. This area between the latissimus dorsi and the external oblique abdominis muscle forms a triangle. Can anybody name this triangle here called as, can anybody name the triangle which is bounded medially by the latissimus dorsi, which is bounded laterally by the external oblique abdominis muscle, and it is bounded inferiorly by the iliac crest. Anybody guys? Very good Anashwara, very good Adira. It is called as the lumbar triangle of Petit. Hernia can also happen through this potentially weak area which is called as an Petit hernia, okay. This is called as lumbar triangle of Petit. Excellent guys, this is called as lumbar triangle of Petit. I think Anashwara, Adira, Muha and Mukundan, everybody, you guys are rocking here. You are studying very well. So I am very happy to be in this crowd, okay. You guys are rocking really. So this is about the lumbar triangle of Petit, which is bounded on one side by the latissimus dorsi and the other side by the external oblique abdominis muscle. Below it is related to the iliac crest. Now if you see the kidney, where is the kidney located? Yes, kidney is located in front of, okay, the quadratus lumborum and the psoas major muscle. It is located in front of the quadratus lumborum and the psoas major muscle. It is where the kidney is located. So when you approach the kidney from the posterior aspect through the renal angle, you need to cut all these layers. You need to cut latissimus dorsi, you need to cut erector spinae, you need to cut the posterior, middle and the anterior layer of thoracolumbar fascia. You need to retract or cut the quadratus lumborum to reach the kidney, and when you see the kidney here closely, okay, the kidney is lined by okay, and capsule, okay. This is a true capsule of the kidney, okay. This is a true capsule of the kidney. So this is the first covering of the kidney also. So this is a covering of the kidney. What does this yellow color represents? This yellow color represents the true capsule of the kidney. This is called as a true capsule of the kidney, okay. And outside the true capsule of the kidney there is a layer of fat which is seen. The fat which is seen is called as a perinephric pad of fat. So what is this fat which is seen here? This is called as perinephric pad of fat. This is called as perinephric pad of fat, which is seen in this region, and surrounding the perinephric pad of fat is the condensation of the fascias in the abdomen, and that forms the false capsule. Okay, that forms a false capsule. This false capsule has got two layers in it. It has got two layers in it. One is called as an anterior layer. Okay, so this layer is called as an anterior layer. Okay, this anterior layer is also called as fascia of Gerota. This is called as fascia of Gerota, and the layer which is present posteriorly is called as the posterior layer, also called as fascia of Zucker-Kandel. It is also called as fascia of Zucker-Kandel. This is also called as fascia of Zucker-Kandel. Is also called as fascia of Zucker-Kandel. Now this false capsule, okay, not only encloses the kidney, when it goes above, it also encloses the suprarenal gland. Okay, when it goes above, it also encloses the suprarenal gland. This is a false capsule, okay, which has got two layers. Anterior layer is called as fascia of Gerota. Posterior layer is called as fascia of Zucker-Kandel. Now outside this, okay, outside this, you also have a pad of fat. You also have a pad of fat outside this. This pad of fat which is present outside this capsule is called as the paranephric pad of fat. This is called as an paranephric pad of fat. This is called as an paranephric pad of fat. So these are all the structures which are covering the kidney. These are all the structures which are covering the kidney. Okay, so this is about the location and the anatomical relationship of the kidney. This is about the location and anatomical relationship of the kidney. Okay, so guys, there are a lot of relations in anatomy. Okay, so we are trying to emphasize only the needed things and important things. If we talk about every organ, every relationship, so okay, so one year will not be sufficient to complete anatomy. So we try to rush up and we try to finish the important things. Now what is the internal architecture of the kidney? See, when you cut the kidney and when you see inside, okay, so you see the following structures. Okay, so the kidney has got an outer cortex. This is called as an outer cortex. This is called as an outer cortex, and the inner one is called as an inner medulla. This is called as an inner medulla. Okay, so this is called as an inner medulla, and this inner medulla is thrown into number of conical projections called as the pyramids. So these are called as the renal pyramids. These are called as a renal pyramids. Okay, these are called as a renal pyramids. So inner medulla contains approximately 10 renal pyramids. Okay, so this 10 renal pyramids narrows down to form an apical projection which are called as renal papillae. These are called as renal papillae. These are called as a renal papillae, and this renal papillae opens into this cup-like cavities which are called as minor calyces. These are called as minor calyces, and this minor calyces opens into next bigger duct which is called as a major calyces. Okay, so major calyces. So approximately 7 to 10 minor calyces are seen, and approximately 3 to 4 major calyces are seen. 3 to 4 major calyces are seen, and all the major calyces finally unite and they form the renal pelvis. Unite and they form the renal pelvis. Okay, unite and form the renal pelvis. Okay, so this is about the internal architecture of the kidney. When you cut the kidney and when you see, so the kidney has got an outer cortex. The kidney has got an outer cortex and has got an inner medulla. Okay, it has got an inner medulla, and this inner medulla is in the form of a pyramidal shaped structure. That is why it is called as a renal pyramid. The tip of the renal pyramid is called as renal papilla. Okay, usually this renal pyramids contains mainly the collecting duct. Okay, mainly the collecting ducts. Okay, so this is the area where you mainly see the collecting ducts, and these collecting ducts finally they converge and they form an apical projection which is called as renal papillae, and these renal papillae opens into the minor calyces which is 7 to 10 in number. They finally opens into the major calyces, and they finally opens into the renal pelvis. So this is about an gross internal architecture of the kidney. Okay, gross internal architecture of the kidney. And so if you see the cortex, okay, if you see the cortex, this cortex forms arches over the renal pyramids. Okay, so these arches are called as a cortical arches. These are called as a cortical arches, and in between the renal pyramids they form a column. These are called as a renal columns. These are called as a renal columns. Okay, so they are called as a renal columns, or they are called as renal columns. So these are all the internal architecture of the kidney. These are all the internal architecture of the kidney. Okay, so kidney is supplied by the renal artery. Okay, so the renal artery divides into 5 branches and supplies the kidney. So these segments are called as the renal or the vascular segments of the kidney. So these are the vascular segments of the kidney. These are all the vascular segments of the kidney. So how they divide the kidney into vascular segments? So if you see the kidney, so let us consider this is the kidney, and this is the anterior side of the kidney, and this is the posterior side of the kidney. Okay, so there is an segment which is called as an apical segment, and there is a segment called as lower segment. Further the kidney is divided into posterior and anterior. The anterior segment is further divided into upper and the middle segment. Okay, so this is how they divide the kidney into 5 segments. So what is this? This segment of the kidney is called as an apical segment, apical vascular segment. This is called as an anterior, so this is called as an upper vascular segment. This is called as an upper vascular segment. This is called as a middle vascular segment. This is called as a middle vascular segment, and this is called as a lower vascular segment. All these segments are seen on the anterior surface or the anterior side of the kidney. These are the vascular segments which are seen on the anterior side of the kidney. On the posterior side of the kidney, the important segment is the posterior segment. So this is the posterior segment which is seen from the posterior side. Okay, which is seen from the posterior side. Now if you take the anterior segment and the posterior segment, in between these two segments you have an relatively avascular zone. You have a relatively avascular zone. So this zone between the anterior and the posterior segments of the kidney is relatively avascular. If you want to do any surgeries, you want to do nephrostomy, you want to open up the kidney, remove the stones, if you want to go inside the kidney, this is a relatively better zone to handle because it is relatively avascular, and this relatively avascular is marked by a line called as Broddel's line. So the Broddel's line represents a zone of avascularity. Zone of avascularity, this is marked by this line called as Broddel's line. This is called as Broddel's line. Okay, so that is the importance of Broddel's line. Okay, so renal artery, okay, renal artery, and the renal arteries, as we have already seen, renal artery is a branch of the abdominal aorta. Okay, it's a branch of the, it's a lateral branch of the abdominal aorta, arising approximately at the level of L2, supplies the renal gland, supplies the kidney, and in a very similar way the kidney is drained by the renal veins. Okay, the kidney is related by the renal veins, drained by the renal veins. And what is more important here is, okay, what is more important here is the structures which are arranged in the renal hilum. Okay, the structures which are arranged in the renal hilum, when you go from when you go from anterior to posterior, when you go from anterior to posterior, it goes by again by the same relationship, that is called as an VAP structure. Okay, that is called as an VAP structure. So the more anterior is the renal vein, the more anterior is the renal vein, then comes the renal artery, and the posterior structure is the renal pelvis. The posterior structure is the renal pelvis. Okay, the posterior structure is the renal pelvis. And when you try to trace the renal pelvis down, the renal pelvis continues as the ureter. The renal pelvis continues as the ureter. Okay, so you got 2 ureters, one on the right side and other on the left side. And when you trace the ureter, okay, the ureter crosses the abdomen. Okay, it shifts over the pelvic brim, enters the pelvis, and opens into the urinary bladder. It opens into the urinary bladder. It opens to the lateral corners of the trigone. It opens into the lateral corners of the trigone. So inside the urinary bladder you get a triangular shaped area which is called as trigone, and this ureter opens into the lateral angle of the trigone. It opens into the lateral angle of the trigone. So if you see the ureter, okay, The ureter, when when it passes across all these areas, there are certain areas where the ureter gets narrowed down. So those are called as the constrictions of the ureter. So those are called as the constrictions of the ureter. Okay, constrictions of the ureter are seen in the following areas. One, at the junction of the pelvis and the ureter, which is called as a pelvic ureteric junction. So this junction is one area where the ureter gets narrowed down, and the next area where the ureter gets narrowed down is the point where it crosses the pelvic brim. At the point where it crosses the pelvic brim, it gets narrowed down, and the point where it is crossed by the vas deferens, okay, it is having a constriction, and the point where it enters the bladder, it has got a constriction, okay, that is called as an utrovesical junction. So where are all the constrictions seen? The constrictions are seen in pelvic ureteric junction. Pelvic ureteric junction, it is seen at the junction of the pelvic brim, okay, when the ureter crosses the pelvic brim, okay. So you can see the constriction. When the vas deferens, okay, when the vas deferens crosses the ureter, you can see the constriction. The point when the ureter enters the urinary bladder, that is the vesico, okay, that is the vesico-ureteric junction, okay. The vesico-ureteric junction, you can see this constriction. Vesico-ureteric junction, you can see this constriction, okay. So these are all the areas where you see the constriction in there. But why do you want to worry about these constrictions? Because we all know that renal stones are very, very common. When the renal stones are formed, when it comes down the ureter, the constriction can lock the stones. Those stones can get locked in these constrictions. When there is a stone which is present, and when it is not able to pass down, it will cause severe pain. That is called as an ureteric colic. Okay, when there is an ureteric colic, the patient will have severe pain which radiates from the loin to the groin region. So the pain will radiate from the loin to the groin region. Okay, so these are all the areas where you see the constrictions of the ureter, okay. So the importance is the stones which are formed in this region. Since we have said about the stones, few things about stones, ureteric stones, okay. So ureteric stones or the renal stones are usually of the following types, okay, I hope you guys have crossed these types. So these are called as calcium oxalate stones. They are called as calcium oxalate stones. Next is called as stag-horn calculi. They are called as stag-horn or triple stones. They are called as triple stones, okay. Okay, can anybody tell me what are the three minerals which are seen in the triple stones or stag-horn calculi, guys? Anybody? What are the three minerals? No, I am talking about stag-horn calculi, Anashwara. What are the three? Yes, very good, Adira, very good. It is magnesium, ammonium and phosphate. That are the three minerals which are seen in the stag-horn calculi. It is not the calcium. In the calcium oxalate stones has got calcium and the oxalic acid, whereas the stag-horn calculi or the triple stone has got ammonium, magnesium and phosphate. Very good, guys. So that is about the stag-horn calculi. So it has got an it is a very big stone. It gives an appearance of a horn of a deer. So it is called as a stag-horn calculi. So there are certain stones which are formed when there is a high level of uric acid. So they are called as an uric acid stones. Whenever a patient has gotten homocystinuria, okay, there is a condition called as homocystinuria. Can anybody tell me homocystinuria occurs due to deficiency of which enzyme? Homocystinuria, okay, homocystinuria occurs due to deficiency of which enzyme? Yes, guys, yes, very good, guys. Yes, it is due to the homogenetic oxidase deficiency that causes homocystinuria, okay, that causes a stone called as cystine stones, okay, cystine stones. Sometimes when you take drugs like indinavir, okay, indinavir, they can cause stones. So they are called as drug related stones. Now what is importance of cystine stones? Cystine stones are the harder, okay, they are the hardest stone among these. So what is the hardest stone among these 16 stones are the hardest stones? What are all the biggest stones? Usually this Staghorn calculi are the biggest stones, and uric acid stones are usually radiolucent stones. Uric acid stones are usually radiolucent stones. Okay, radiolucent stones. See, sometimes a patient comes to you. Okay, sometimes a patient comes to you and he says that, sir, I have got a pain in the loin region. Okay, so he has got a pain in the loin region. Now you take an X-ray. Okay, on the right side you take an X-ray. Now you see a stone on the right side. Okay, you see a stone on the right side. So let us consider this is a patient X-ray. So you see a stone on the right side. This is the right side. You see a stone on the right side. Now, can anybody tell me how to differentiate this stone as a renal stone or a gallstone? What view you will take to differentiate a renal stone from a gallstone? Okay, so you have a stone on the right side. Very good, Anashwara, very good. So when you want to differentiate a gallstone from the renal stone, you need to take a lateral view. You need to take a lateral view. So when you see the lateral view, you see the vertebrae here. You see the vertebrae here. If you see a stone in front of the vertebra, if you see a stone in front of the vertebra, then that is gallstone. If you see a stone over the vertebra, okay, if you see a stone over the vertebra, because the kidney is occupying the para-vertebral gutter, it is occupying the para-vertebral gutter. So when there is a stone, the image will superimpose the vertebra. So when the image superimpose the vertebra, these stones are called as the renal stones. These stones are called as the renal stones, and these are called as the gallstones. These are called as the gallstones. So if you want to differentiate renal stone, if you want to differentiate renal stone from a gallstone, what view you need to take? You need to take the lateral view. You need to take a lateral view. Okay, so this is about the constrictions of the ureter and the ureteric stones here. Next is the relationship of the ureter. Again, I'm telling you, don't worry much about the relationship, just have an idea. Okay, so if you see on the right side, the ureter is related to the second part of the duodenum. It is related to the right colic vessels and the ileocolic vessels, branches of the superior mesenteric artery, and it is also related to the right gonadal vessels and to the right or to the root of the mesentery. Okay, when we studied about the root of the mesentery, we saw that it is crossing the ureter. Okay, I think you remember, guys. Okay, so I think we discussed here. So if you see here, you can see the root of the mesentery. Okay, and I have told about the root of the mesentery is crossing the right ureter here. So that is what we are seeing here. Okay, so what we see here is, so when the ureter is running down, it is being crossed by the root of the mesentery on the right side. So these are all the relationship on the ureter on the right side, mainly the abdominal part. When it comes to the left side, the left side ureter is related to the left colic vessels. Okay, it is related to the sigmoid vessels on the left side, and it is also related to the left gonadal vessels, and it is related to the sigmoid mesocolon on the left side. So on the right side, the right ureter is related to the mesentery, which is a peritoneal fold, and on the left side it is related to sigmoid mesocolon, which is also a peritoneal fold. Okay, now after crossing all this, the ureter enters the pelvis. Okay, it enters the pelvis, and at the junction of the ischial spine, it turns anteriorly and opens into the trigone of the bladder. Okay, so if you take the bladder here, so it runs into the bladder and it opens into a trigone of the bladder. Okay, so trigone of the bladder, it is devoid of the mucosal folds. You can see the opening and the lateral ends of the trigone. Okay, fine. So whenever the ureter opens at the ends and the trigone, okay, so what happens is, sometimes the ends of the ureter can dilate and it can form a condition called as ureterocele. Okay, it can form a condition called as ureterocele. What is called as an ureterocele? Dilatation of the ends of the ureter is called as ureterocele. It is called as an ureterocele. Okay, when you have an ureterocele, if you do an intravenous pyelogram, okay, what is called as ureterocele? the dilation of the ends of the ureter. The dilation of the ends of the ureter are called as an ureterocele. The dilation of the ends of the ureter are called as ureterocele. So whenever there is a dilation, if you do an intravenous spielogram, it gives a classical appearance. Can anybody tell me what is the appearance? Very good, guys. It is called as an cobra head. It is called as an cobra head or adder head appearance. It is called as an cobra head or an adder head appearance. It is called as an cobra head or an adder head appearance. Very good. It is called as an cobra head or an adder head appearance. Now when you see the ureter, okay, as we know that the ureter is derived from the ureteric bud, okay, and the main kidney is derived from the metanephric blastema, and this kidney formation occurs in the pelvic region, and after that, as the differential growth of the abdomen happens, kidney ascends and the gonads descends. Okay, so what happens is when the kidney is formed sometimes, okay, so the lower poles of the kidney can get fused. Okay, the lower poles of the kidney can get fused like this. When they get fused like this forms a type of kidney called as horseshoe kidney. Okay, they form a type of kidney called as horseshoe kidney. They form a type of kidney called as what? They form a type of kidney called as horseshoe kidney. Okay, when the horseshoe kidney is formed, when the pelvic, when the kidney tries to ascend, okay, so it cannot ascend further because of one structure that is preventing the ascent of the kidney, and the structure which is preventing the ascent of the kidney is an artery which arises from the ventral side of the aorta, arising at the level of L3, and that artery is nothing but the inferior mesenteric artery. That artery is nothing but the inferior mesenteric artery. When you have an horseshoe kidney, okay, so when you take an intravenous spielogram again, you get a classical appearance here, that is called as a flower vase appearance. You get a classical appearance called as a flower vase appearance. Okay, you get a classical appearance called as flower vase appearance. Okay, now when you take the ureter, okay, just I want to ask you, ureter is an peritoneal organ or an retroperitoneal organ. What is that, guys? Ureter is what? Is it covered by peritoneum on all the sides? It is an intraperitoneal organ or it is an retroperitoneal organ? Very good, Anashwara. It is an retroperitoneal organ. Now there is a condition called as retroperitoneal fibrosis. Okay, so the tissues in the retroperitoneal area, when they get shrink, when they shrink, okay, because of fibrosis, that is called as an retroperitoneal fibrosis. When there is a retroperitoneal fibrosis, okay, what happens is, if you do again an intravenous spielogram, okay, you can see the two ureters coming close together in the abdominal region, and then they reach the pelvis like this. Okay, so they come close together. Okay, very good Vinitha, very good, guys. So this is called as an maiden waist appearance. Hey guys, what here over radiology class is over for you? Radiology class is over for you? Yes. So this is called as Weiden Mace appearance. You guys are rocking here. Yes, very good. So this is just like a revision class then. Okay, so retroperitoneal fibrosis, when it happens, it can pull the ureter towards one another. It gives a maiden waist appearance. Okay, sometimes what happens is, if you see the relationship of the ureter, okay, here, okay, you can see the relationship of the ureter. The ureter is running to the right side of the inferior vena cava. If you see the ureter, it is running to the right side of the ureter. So it is running to the right side. Okay, it is running to the right side of the vena cava. Sometimes vena caval anomalies can happen, and the ureter can run behind the vena cava. Sometimes the ureter can run behind the, okay, vena cava. So that condition is called as retrocaval ureter. So whenever there is a retrocaval ureter, okay, again, when you do an intravenous spielogram, you will get J-shaped ureter. You will get a ureter called as J-shaped ureter. You get an ureter called as J-shaped ureter. Okay, you get an ureter called as J-shaped ureter. Okay, and this ureter, when it enters, okay, when it enters into the urinary bladder, okay, I hope you all know that below the urinary bladder there is an structure called as prostate. When the prostate enlarge, okay, again it gives a classical appearance. We'll discuss that when we come to the prostate. Okay, so here it is called as an J-shaped ureter. Here it is called as an J-shaped ureter. Okay, see, whenever you have the ureter, okay, so anomalies can happen in the ureteric formation also. Anomalies can happen in the ureteric formation also. See, for example, when you take the kidney, okay, when you take the kidney, instead of one ureter, sometimes two ureters can come down. Okay, sometimes two ureters can come down. Okay, so this is called as duplication of the ureter. This is called as a duplication of the ureter. Okay, so when the ureter is duplicated here, okay, so you got two ureters. Okay, so when they come down, they open into the urinary bladder. And where do they open? Okay, if you see, this is the urinary bladder. Okay, if you see, this is the urinary bladder. Okay, I'll just draw it a little bit down. Okay, so this is the urinary bladder. Okay, so this is urinary bladder. If you see the upper moiety ureter, this is called as an upper moiety ureter. This is called as an upper moiety ureter. When you see the upper moiety ureter, this will run more inferiorly and it will open more medially. It will run more medially. This is an usually the upper moiety ureter is an abnormal ureter. The upper moiety ureter is an abnormal ureter. It opens at an abnormal place, whereas the lower moiety ureter will open at the routine site into the lateral aspect of the trigone. Okay, so usually whenever there is an upper moiety ureter, it opens inferiorly and medially. The lower moiety ureter will open superiorly and laterally. Okay, one they will open inferiorly and medially, and the other, that is the lower moiety ureter, opens, the lower moiety ureter opens superiorly and laterally. Okay, so this is governed by a law called as Weigutt-Mayer law. So there is a law which is called as Weigutt-Mayer law. So what does Weigutt-Mayer law says? So if it is an duplicated ureter, very good Anashwara, very good. So when there is a duplicated ureter, the upper moiety ureter will open more inferiorly and medially, whereas the lower moiety ureter will open in the normal position. Okay, it is slightly upper and lateral, and this upper moiety ureter, again it can go in for a dilatation at the end, which is called as an ureterocele, and the lower moiety ureter will have vesico-ureteric reflex. It can go in for vesico-ureteric reflex. It can go in for vesico-ureteric reflex. Okay, so this is about the anomalies. There are a lot of anomalies. I think they would have discussed in radiology sessions. So just to brush up, I want to touch all these regions. Okay, so ureter, as you see, these are the important things related to ureter. Okay, so with this we'll move to the next part of our class. Okay, so coming to the perineum. Okay, coming to the perineum, just a second guys. So we are talking about perineum now. See, when you see the perineum, okay, what is this view basically? What is this view basically? This is a lithotomy view. So when you put a patient in the lithotomy, okay, when you put the patient in the lithotomy, okay, like this, when you put the patient in the lithotomy, so this triangle, what you see, okay, this region, what you see is the perineum, and that is what you see here. So this is an lithotomy view, or is a view from the inferior aspect of the pelvic region, and this region, what you see here is the perineum. See, when you see the perineum is bounded on the sides and on the front by the following structures. Okay, so it is bounded by the following structures. So the perineum is bounded anteriorly by, okay, it is bounded anteriorly by the pubic symphysis, okay, by the pubic symphysis. And can anybody tell me pubic symphysis is what kind of joint? Anybody? Pubic symphysis is what kind of joint? It is a synovial joint, or it is a cartilaginous joint, or it is a fibrous joint. Pubic symphysis is what kind of joint? Yes, it is an secondary cartilaginous joint. It is lying in the midline of the body. It is secondary cartilaginous joint. So close to the pubic symphysis you have a ligament here. This is called as an arcuate pubic ligament. What is this ligament called? This ligament is called as an arcuate. This is called as an arcuate pubic ligament. This is called as an arcuate pubic ligament. Okay, this is called as an arcuate pubic ligament. So this pubic symphysis and arcuate pubic ligament forms the anterior most boundary for the perineum, and on the lateral side you get this rami. Okay, so this rami which you see on the lateral side is called as the conjoint ischiopubic rami. This is called as an conjoint ischiopubic rami. This is called as an conjoint ischiopubic rami. So the rami which you see on the anterolateral aspect, so the anterolateral boundary, is formed by the conjoint ischiopubic rami. Now what is this boundary? This boundary is the posterolateral boundary. This is called as the posterolateral boundary, and the posterolateral boundary is formed by the sacrotuberous ligament. It is formed by the sacrotuberous ligament. Okay, it is formed by the sacrotuberous ligament. Okay, so you got two anterolateral boundaries and you got two posterolateral boundaries. You got one anterior boundary, and what is the structure forming the posterior most boundary? So the posterior most boundary is formed by the coccyx bone. It is formed by the coccyx bone. Okay, it is formed by the sacrum and the coccyx here. So these are the structures which are forming the boundaries of the perineum. Okay, if you see the perineum is like a diamond shaped fossa. Can anybody tell me one another structure in the body which has got a diamond shaped fossa, which has got four boundaries like this? Superolateral, superomedial, infrolateral, very good. It is popliteal fossa. Very good, guys. It is popliteal fossa. So very similar to that, you have got a fossa here, or we have got an area here which is called as a perineum, and this perineum is divided into two halves by an imaginary line. Okay, so this imaginary line is running through the perineal body, and they divide it into two triangles. The anterior triangle is called as an urogenital triangle, and the posterior triangle is called as an anal triangle. The posterior triangle is called as what? Anal triangle. Okay, the posterior triangle is called as anal triangle. So in the posterior triangle, in the anal triangle, you get an important structure which is the anal canal. Okay, so you get an important structure called as anal canal. So if you draw here, okay, I'll just draw it here. Okay, so I'll just draw here. So if you take the perineum, okay, so this is the posterior part or the anal triangle. In the anal triangle you get the anal canal. Okay, so this is anal canal. This is the anal canal, or the opening of the anus. Okay, on either side of the anal canal you get a space or a fossa which is called as ischio-anal or ischio-rectal fossae. It is called as an ischio-anal or ischio-rectal fossae. Okay, ischio-anal or ischio-rectal fossae, that is what we are going to see now. Very, very important topic, ischio-rectal fossa or ischio-anal fossa. Okay, so where this fossa is, what are the boundaries of the fossa, we are going to see. Okay, so this fossa is present on either side of the anal region in the anal triangle. Okay, so if you see here, okay, I'll just make a simple diagram so that you can understand the structures very well. So this is the anal canal. Okay, so this is the anal canal. Okay, this is the anal canal. Okay, fine, this is the anal canal. This anal canal passes through an opening in a diaphragm, that is the pelvic diaphragm. So the muscle which is forming the pelvic diaphragm is this one. Can anybody tell me what is the other name for pelvic diaphragm? Yes guys, what is the other name for pelvic diaphragm? So there is an opening in the pelvic diaphragm through which the anal canal comes down to the outer aspect. Yes, very good guys, this is called as levator ani. Very good guys, this is called as levator ani. Okay, if you see the levator ani is attached to the pelvic bone to the sides. On the sides it is attached to the pelvic bone. So I am just drawing a bone here. So the bone which you see here, okay, is the pelvic bone, okay, is the pelvic bone. And what part of the pelvic bone here? This part of the pelvic bone, what you see in this picture is the ischium. So what you see here is in the ischium, okay, it is in the ischium, okay. So you have got three parts, so I am just drawing ischium here, okay. So it is ischium. Now on the inner aspect of the ischium, okay, so you can see a muscle which is attached. So the muscle which is attached to the inner aspect of the ischium is called as the obturator internus muscle. This muscle is called as what? This muscle is called as an obturator internus muscle. So what is this muscle? So this muscle, what you see here, is called as an obturator internus muscle. So this muscle is obturator. This is called as obturator internus muscle. This is called as obturator internus muscle. This is called as obturator internus muscle. Okay, so when you see the outer aspect of the body, okay, so you can see the skin, okay, you can see the skin of the gluteal region is continuous with the skin of the anal region. So you get the skin here. So what is this? This represents a skin. This represents the skin, okay. Now below the levator ani muscle, you get fascia, okay. This is called as the inferior fascia of the pelvic diaphragm. This is called as an inferior fascia of the pelvic diaphragm, okay. So what is this fascia? This is called as an inferior fascia of the pelvic diaphragm. This is called as an inferior fascia of the pelvic diaphragm. And similarly, the obturator membrane is covered by a, the obturator muscle is covered by a fascia. This fascia is called as an obturator fascia. So what is this fascia? This is called as an obturator fascia. This is called as an obturator fascia, okay. And this obturator fascia goes above and it is continuous with this fascia of the inferior fascia of pelvic diaphragm. Since they form an arch here, this arch is called as lunate fascia. What is this fascia? This is called as lunate fascia, okay. I'll just repeat once again. Below the levator ani you get a fascia which is called as the inferior fascia of the pelvic diaphragm. On the sides you have the obturator internus muscle. This obturator internus muscle is covered by a fascia, okay. So this obturator internus muscle is covered by a fascia which is called as an obturator fascia, which makes a connection with the inferior fascia of the pelvic diaphragm. So it forms a lunar shaped structure. That is why it is called as an lunate fascia. That is why it is called as an lunate fascia. That is why it is called as an lunate fascia, okay. Now in the anal canal, I hope you know that there is an area called as white line of Hilton, okay. So from the white line of Hilton, a septum runs laterally to the obturator fascia like this, okay. So there is a septum which is present here, okay. There is a septum which is present here, okay. So this septum divides the ischioanal fossa into a small lower part. This portion which is below the septum is called as an perianal space. It is called as an perianal space. It is called as an perianal space, okay. It is called as an perianal space. And the space above is called as an ischioanal space, okay. The space above the septum, okay. So this is a space which is present here, and this space is further divided into infrategmental space and suprategmental space. So what is this space now? This space is called as an infrategmental space. It is called as an infrategmental space, okay. And this space what you see here is called as an suprategmental space. It is called as an suprategmental space, okay. So these are all the divisions of the ischioanal fossae. These are all the divisions of the ischioanal fossae. So the ischioanal fossa is divided into suprategmental space, infrategmental space and perianal space. And what happens in the perianal spaces? This perianal space is divided into small loculae by means of this septus, okay. So there are fibrous bands which runs from the septum to the skin, dividing the perianal space into small areas. When you have this small areas, so the fat in these areas, when they get inflamed, okay, when they get inflamed, or if there is an external hemorrhoid, when it enlarges, you don't have space for things to enlarge because of several fibrous septae. So whenever an infection in the perianal space occurs, it will be very painful. So okay, it will be very painful. Okay, so whenever there is multiple septae, okay, and if this multiple septae are, these are all fibrous septae which will not allow the things to expand. Okay, so when there is an inflammation, when there is an edema, this won't expand, and when it won't expand, it results in severe pain. Okay, so whenever there is an perianal infection or whenever there is a perianal abscess in this space, it will be very painful. Can anybody correlate this with another area in the body where you get a similar kind of small septae dividing a space? Okay, can anybody tell me the name of the space where you get a similar kind of fibrous septae dividing it into small areas? Again, an inflammation or infection in that area will be severely painful. Can anybody tell me what is that space called as? Very good, Vinita. It is called as space of Whitlow, also called as, okay, it is also the infection is also called as phelon. It is called as phelon. Okay, I hope you know this. So let us consider this is the finger and this is the nail. Okay, so this is the pulp. Okay, so this is the pulp. Okay, so this is the pulp. So when you see the pulp of the finger is divided into multiple areas by means of septae. So this space is called as pulp space. This is called as pulp space. Infection in the pulp space results in severe pain, which is called as the phelon, This condition is called as phelon. This condition is called as what? Phelon. This condition is called as phelon. Okay, so similar to that happens in this area. So this is called as in perianal space. Okay, this is called as in perianal space, and what is present in the perianal space is also a part of the external anal sphincter. Okay, so that part which is present here is the subcutaneous part. Okay, external anal sphincter has got three parts, and the part which is seen here is called as an subcutaneous part of external anal sphincter. This is called as a subcutaneous part of external anal sphincter. It is called as a subcutaneous part of the external anal sphincter. Okay, so this is about the perianal space. And when you come to the infrategmental space, or if you take the ischianal space per se, you have got this ischianal space extending anteriorly, forming the anterior recess. Okay, and it extends posteriorly behind the sacrotuberous ligament, forming the posterior recess. Okay, so you can see the anterior recess in the ischianal fossa. You can see the posterior recess. So these are all the recesses, or these are all the extensions of the ischianal fossa. So two ischianal fossas will communicate with one another behind the anal canal, so forming a recess called as an horseshoe recess. So when you take the anal canal, so the space around the anal canal is called as what? It is called as an ischianal space. So that space is continuous anteriorly up to the pubic bone, that is called as anterior recess. It extends posteriorly behind the sacrotuberous ligament, so that is called as a posterior recess. It can communicate with the opposite side, forming a recess called as what? It is called as an horseshoe recess. Okay, so these are all important things to be noted here. Now when you see the obturator fascia, okay, which is present on the lateral wall of the ischioanal fossa, this obturator fascia again splits here, and it encloses a canal, and this canal is called as pudendal canal, also called as Alcock's canal. So what is this canal? So this canal, what you see here on the lateral wall of the ischioanal fossa, is called as an pudendal canal, also called as an Alcock's canal, Okay, so if I say Alcock's canal or pudendal canal, it carries three structures in it, which goes by the same mnemonic pin. Can anybody tell me what is called as a pin structure, which we saw yesterday, winding around the ischial spine? Can anybody tell me what are the pin structures which we saw yesterday, which were winding around the ischial spine? Yes, one is pudendal nerve. Very good. Next one is internal pudendal vessels. Next one is internal pudendal vessels. That is the internal pudendal artery and the vein, that is internal pudendal vessels. Next is nerve to obturator internus. These three structures runs through the pudendal canal, which is also called as Alcock's canal. As you see in the picture, the obturator internus, nerve to obturator internus will supply the obturator internus. Pudendal nerve and the internal pudendal vessel will supply the perineal region and the anal region, okay, and they supply the anal region. So if you see an artery here, this artery is pudendal artery, okay. So internal pudendal artery supplies a branch to the lower part of the anal canal, that is called as the inferior rectal artery, and a similar way the pudendal nerve will supply a nerve to the anal canal here. So that nerve will be the inferior rectal nerve. 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 So these are all the important things to be noted in this region, okay, noted in this region, okay. So when you take the contents here, so these are all the contents of the ischianal fossa. So inferior anal nerve or the inferior rectal nerve or the one we saw, internal pudendal vessel, branches, pudendal nerve top, all these things we have seen. The posterior scrotal and the labial vessels also you can also see the branches from S2, S3 and S4, okay, penetrating the perianal region. So these nerve roots also you can see in this, okay, the fibers of these nerve roots also you can see in this. So these are all the contents of the ischioanal fossa. These are all the contents of the ischioanal fossa. Now what is the main pathology that occurs in the ischioanal fossa is, many times infection can happen in this ischioanal fossa, and it can form an abscess which we call it as an ischioanal abscess or ischio-rectal abscess, okay. So suppose if you have an abscess, okay, so an abscess is formed here, okay. So this abscess is called as an ischioanal or an ischio-rectal abscess. So whenever there is an abscess, we have a tendency to drain the abscess, okay. So when we try to drain the abscess, there is a nerve which runs from the lateral wall of the ischioanal fossa to the distal part of the rectum, which is called as a distal part of the anal canal, that is called as an inferior anal nerve or inferior rectal nerve. So when you try to drain the abscess, in the ischioanal fossa, inferior rectal nerve can be damaged, okay. So inferior rectal nerve can be, yes, Anashwara, inferior rectal nerve is a branch of pudendal nerve. Yes, it is a branch of pudendal nerve, that is right. Inferior rectal nerve is a branch of pudendal nerve. It is also called as an inferior anal nerve, okay. So inferior rectal nerve, when it gets cut, okay, okay, it can cause fecal incontinence. The external sphincter will loses its tone. It can cause fecal incontinence. Okay. So the next pathology which is seen in this region is, you can see the origin of the levator ani muscle here, okay. The origin of the levator ani muscle, when it becomes deficient, it can result in an hiatus which is called as hiatus of Schwalbe. It is called as hiatus of Schwalbe, okay. So when the origin of the levator ani muscle here, when it becomes deficient, it can result in an hiatus. It can result in an hiatus which is called as an hiatus of Schwalbe, okay. So if there is an hiatus here, the pelvic contents can come into the ischioanal fossa to form an hernia in this region. So this is called as hiatus of Schwalbe. What is called as an hiatus of Schwalbe? It is an defect at the point of origin of the levator ani muscle. At the point of origin of the levator ani muscle, if there is a defect, we call that as hiatus of Schwalbe. That is called as an hiatus of Schwalbe. We have seen these kinds of defects in the diaphragm. I hope there is a defect in the posterolateral aspect of the diaphragm that results in an hernia. Can anybody name the hernia which occurs in the diaphragm because of the defective origin of the diaphragm in the posterolateral aspect? It is called as Bog-Dallach hernia. Very good, guys, very good, Adira. It is called as an Bog-Dallach hernia. If the same kind of hernia in the diaphragm happens on the anterior portion, what is that hernia called as? Is the same kind of hernia, a small hernia that can happen on the anterior portion of the diaphragm. Very good, guys, that is called as Morgagni's hernia. That is called as Morgagni's hernia. So I think we are going into the pathologies of this ischial fossa, and we are done with the pathology of the ischial fossa. Okay, fine. So hope this area is clear, and we'll take a break now, and when we resume after the lunch, we'll start with the rest part of the abdomen, and we'll try to finish the abdomen, and we'll try to start head and neck as early as possible. Okay, fine. So have a lunch and take rest and come back. We'll resume after this.